Just a little disclaimer, all thoughts and opinions are my own and do not represent those of Envision Physician Services, HCA, or HCAVA. I have no conflicts of interest to disclose. So let's start with a case scenario. 38 and 2/7 week pregnant mother presents in labor on Saturday. Their prenatal care was done in Alaska. They just moved here. Plan is to acquire prenatal labs on Monday. The infant delivered vaginally with APGARs of 9 and 9, but has this significant nasal discharge thought to be just amniotic fluid. The infant is transferred to Well Newborn and discharged after 2 days. This is what the infant's nasal discharge looks like. The RN who took care of the mother-baby dyad in labor and delivery returns to work the next week with this. What is that? That's a syphilitic chancre. So the nasal discharge that the infant had was actually not just amniotic fluid, it was highly infectious. It's something called the syphilitic snuffles, syphilitic rhinitis. It's full of the syphilitic bacteria, the Treponema pallidum. The RN who took care of the dyad had a paper cut or something, got infected, and this is the result. A similar case scenario, 38 and 2/7 weeker, presents in labor on Saturday, prenatal care in Alaska, plan to acquire labs on Monday, delivered vaginally, good APGARs, transferred to Well Baby, and discharged after 2 days. The parents, however, refused the Hep B vaccine. 1 year later, the infant has easy bruising, abnormal coag profile, and hyperbilirubinemia, and is admitted to the PICU and eventually dies of liver failure. What went wrong? Again, knowledge is power, right? So this could be part of the armament of information that you could have to counsel parents on situations like this. Refusing Hep B vaccine increases the chronic infection risk by 70 to 90% if mother is infected. And, of course, most of the mothers who have hepatitis B, generally they don't refuse the Hep B vaccine. But again, this is a good piece of information to know in your armament. Similar scenario, 38 and 2/7 weeker, presents in labor on Saturday, prenatal care in Alaska, good APGARs, transferred to Well Baby, plan to acquire prenatal labs on Monday, discharged after 2 days. Parents refuse the erythromycin eye ointment. Now, what is this? This is ophthalmia neonatorum, or otherwise known as a neonatal conjunctivitis caused by gonorrhea. If this baby doesn't get treatment right away, not just eye irrigation, but also IV antibiotics for a couple of weeks, this baby will go blind. And if it becomes systemic, could have meningitis from gonorrhea, etc. And we'll talk about this in future slides. So what are the routine prenatal labs? Of course, there's HIV, RPR, and VDRL, and if positive, syphilis-specific antibodies, hepatitis B surface antigen, gonorrhea, chlamydia, and group B strep. There's some additional history that may or may not be included in the routine prenatal labs, but they're still important maternal history. A history of herpes simplex virus, HSV, tuberculosis, maternal thyroid disease, maternal lupus, Zika, and we'll also talk about some breastfeeding contraindications later on as well. So there was a study done in 2022 that looked at the frequency of diagnostic errors in the NICU. It was a retrospective study looking at 600 inborn admissions to the NICU. They saw in those 600 admissions 37 diagnostic errors, 6.2% of them. The most common process breakdowns were in number 1, missed maternal history findings, and number 2, incomplete physical exam findings. The most common main disease category, infectious disease, okay? And then number 2 is renal. In 3 cases, error potentially contributed to a patient's death. So maternal history findings and infectious disease. both of those things are basically what routine prenatal labs are. And as I spoke about, there are other parts of maternal history that are important too. So let's first talk about GBS. So intrapartum antibiotic prophylaxis, or IAP, reduces vertical transmission and invasive disease. When do we test? It's culture-based screening at 36 to 37 and 6/7 weeks, or when a woman is in preterm labor, and or when a mother has PPROM before 37 weeks. Point of care nucleic acid amplification tests, and you may have obviously heard of like PCR tests. PCR is a type of NAAT. That's being explored, but it's not widely recommended as the primary screening approach. When do we give intrapartum antibiotic prophylaxis? Well, I think most of you know kind of the typical indications: GBS positive in labor, etc. But some other indications to consider: previous history of invasive GBS, even if greater than 37 weeks, if mom is GBS unknown, with risk factors that develop, like if she has a fever, prolonged rupture, or is GBS NAAT positive, or even if the mom is NAAT negative and other risk factors develop. Consider if GBS is unknown in the current pregnancy but has had a history of GBS colonization. So what is adequate treatment considered? Well, it's only just 3 antibiotics, actually: penicillin, ampicillin, and Ancef, and only if it's greater than or equal to 4 hours before delivery. Clinda is for those who have a penicillin allergy with a low risk of anaphylaxis. However, 42% of GBS is resistant to clindamycin, so you must have antibiotic sensitivity results to justify its use. Vanc is for those with penicillin allergy with a high risk of anaphylaxis, if they're colonized with clindamycin-resistant GBS. And notably, neither of these, vancomycin nor clindamycin, are actually considered adequate treatment. Now, you might ask why that is. It's because not only this high amount of resistance with clindamycin, but it's also been shown to be less effective than beta-lactam antibiotics like penicillin or ampicillin. In terms of vancomycin, the pharmacokinetics actually suggests that there might not be enough penetration into the fetal tissues. So, and there's a lack of controlled trials to evaluate vancomycin for this purpose. So for now, it's just penicillin, ampicillin, and Ancef. So this is the GBS secondary prevention algorithm from the CDC, and it kind of helps with some decision making on, what do you do in the cases of moms with choreo, or moms who are GBS positive, who are treated, who are untreated. And I just wanted to show you this to give you an idea of where we get those time frames of observation: 48 hours, not 48 hours. And there are some little asterisks on parts of this algorithm that where there are notes where there are specific cases where you can just observe for 36 hours or somewhere between 36 and 48 hours. So I just wanted to, this is freely available. I just wanted to show you this to give you an idea of where this all the 48 hours things comes from. So HIV. The risk of infection for the infant born to an HIV-positive mother without any interventions to prevent the transmission are between 22.6 to 25.5% in the United States. If mom's viral load is controlled, it becomes less than 2%. How are newborns usually exposed? During birth, through blood. So what if mom's HIV status is unknown and she didn't decline it? Mom should be tested. Mom or infant should be tested if necessary, and this could be a rapid antibody test. However, some states actually differ on how mandatory HIV testing is. What are the risk factors for transmission of HIV? A high maternal viral load greater than 1,000, or a maternal CD4 less than 200. However, transmission to the infant has been documented across the entire range of maternal viral loads. If mom had newly acquired HIV, especially during the last trimester, and or if there have been prolonged rupture of membranes, chorioamnionitis, preterm, or a fetal scalp electrode has been placed, because obviously you're breaking the infant's skin, and also the baby could be exposed through maternal blood through that break in the skin. What do we need to do after birth? So that the birth exposure with the blood, that is why we have to bathe the infant and clean the infant of the maternal secretions as soon as possible, ASAP. We should test the baby, send a HIV DNA or RNA PCR right away. Cord blood is not acceptable because you can get false positives from maternal contaminants. You get a baseline CBC for the baby, and the baby needs to begin zidovudine or AZT, HIV medication, within 8 to 12 hours of birth. And this will continue for 6 weeks. Okay. What if mom's maternal load is high, and or if mom had no treatment, no antiretroviral treatment? In this case, is a high risk for transmission. So the infant may need a 2 or 3 drug regimen, including nevirapine. We need to make sure, obviously, that both mother and infant get meds before they leave the hospital. Syphilis. If untreated, up to 40% of pregnancies result in spontaneous abortion, stillbirth, and death. Newborns are usually exposed transplacentally, so through the placenta. What are the early signs? Hepatosplenomegaly, copious nasal secretions, as we saw in the first photograph. It's highly infectious with syphilitic bacteria. They can have brain hemorrhages, lymphadenopathy, pneumonia, chorioretinitis, osteochondritis, pseudoparalysis, edema, rash, hemolytic anemia, and thrombocytopenia. And this is a photo of an example of kind of the palms and soles rash that you can see, but it can also be on other parts of the body as well. These rashes are full of the syphilitic bacteria as well. And this picture is just a picture of the generalized sequela of syphilis. It could be as severe as fetal hydrops and stillbirth, and many other things, not just the skin and the nasal discharge, but the bone, the liver, the brain, etc. So if it's not treated, it can result in late congenital syphilis, and that results in frontal bossing, a saddle nose deformity, a high arched palate, short maxilla, perioral fissures, bowing of the shins, hydrocephalus, seizures, deafness, mental deficiency, just a whole wide range of permanent defects in an untreated case of syphilis in a baby. And it's just an example of some of those deformities. What do we need to do after birth? So RPR and VDRL are actually non-specific tests, meaning you can have a reactive RPR for different reasons. You can actually have a reactive RPR from medications or even autoimmune disease. So if you do have a reactive RPR or VDRL in the pregnancy, you got to get a syphilis-specific test to confirm, and that's usually syphilis-specific antibodies. If syphilis is confirmed, you must be treated with penicillin and penicillin only, and at least for 4 weeks prior to delivery. You have to complete 4 weeks of treatment, a full 4 weeks, before your baby is born. When do we worry? Even if the mom is treated adequately, if the RPR or VDRL titer does not decrease fourfold. So RPR and VDRL are used to measure the effectiveness of treatment. Say, for instance, if a mom starts with an RPR of 1 to 32 before treatment, it needs to decrease fourfold. So it needs to decrease to 1 to 8. Okay, and this is how the ratios will be shown on the prenatal lab results. So when do we evaluate babies? What cases? So if maternal syphilis is untreated, if the treatment was with a non-penicillin drug, if the treatment was less than 4 weeks before birth, so if it's 27 days, not 28, if it's only 26 days of treatment, not 28 days of treatment, then the baby needs to be evaluated. If mom does not have an appropriate serologic response, that's another time we need to evaluate the baby. So meaning if that titer, that initial titer, for example, 1 to 32, only goes down to 1 to 16, that's not enough. Then the treatment may have not been effective enough. So we need to evaluate the baby. Obviously, if the baby is symptomatic, then what do? We have to admit that baby to the NICU automatically, and the baby needs a full workup, either RPR or VDRL. By the way, if mom's treatment has been monitored with RPRs, you need to use RPRs to monitor treatment for the mom, but also only an RPR would be an appropriate test for the baby. If the mom was being monitored with a VDRL, then you need to test the baby's VDRL, etc. Okay, so if you use RPR, stay with RPR. If you use VDRL, stay with VDRL. Baby's going to need syphilis-specific antibodies, a chest X-ray, an LP, long bone X-rays, LFTs, an eye exam, and we'll need IV penicillin for 10 to 14 days. There are certain cases, though, where only 1 dose of benzathine penicillin is acceptable. And there's an entire algorithm for this, but usually in these new cases recently, I've just been calling infectious disease to kind of verify what the exact right course of treatment is. One report looked at 66 cases of diagnosed syphilis. 83% of these cases had prenatal care. 26% had syphilis diagnosed in the pregnancy. 42% not until after the pregnancy. 24% actually had an initial negative test and then seroconverted during the pregnancy. What was wrong? There were 2 factors. There was inadequate adherence to screening and treatment guidelines. There was a failure to identify women for whom repeat screening at 28 weeks and delivery, where that would be recommended. So what's the learning lesson here? That we must be vigilant in reviewing prenatal records and advocate for proper maternal testing and treatment, and advocate for proper infant testing and treatment. Some advocate for testing at delivery, even if tested at 28 weeks in certain syphilis endemic areas. As of, I guess this was 2018, Virginia ranked as 30th in the U.S. at 7.7 per 100,000 cases per the CDC. Hepatitis B. 0.8% of pregnant women are hepatitis B surface antigen positive. The greatest transmission risk is at birth. Okay, it does cross the breast milk, but it's actually low in transmission through the breast milk. Why worry about hepatitis B? Well, 70 to 90% of newborns will become chronic hepatitis B carriers if the mom has disease with high viral replication. And what are the complications? Liver cirrhosis and liver malignancy. So hepatitis B vaccine is actually the most effective method to prevent hepatitis B transmission. Who gets it? All full-term infants. And if you're preterm, if you're 2 kilograms on day of life 30 or at discharge, whatever is first. So if you have a 1,900 gram infant and it's the day of discharge, they get the Hep B vaccine. So what do you do if mom is hepatitis B surface antigen positive? Well, you give Hep B vaccine and hepatitis B immune globulin, or HBIG, within 12 hours at different intramuscular sites. So Hep B vaccine in one leg, HBIG on the other. If the infant is less than 2 kilograms, this immunization does not count on the normal 3-dose schedule. The hepatitis B vaccine is 75 to 95% effective in preventing transmission if given in less than 24 hours. If you add on HBIG to that, it decreases it another 0.7 to 1.1%, so 96% effective. The Immunization Action Coalition reported greater than 500 hepatitis B history errors from 1999 to 2002. In these cases, there was no maternal hepatitis B surface antigen result. It was misinterpreted, it was falsely negative, or it was reported to the care team incorrectly. The safety net for that is hepatitis B vaccine within 24 hours. So if mom is hepatitis B surface antigen unknown, test the mom's stat. In this case, I would give the hep B vaccine within 12 hours. If the infant is less than 2 kilograms, you actually have to get the HBIG within 12 hours. If you're more than 2 kilograms, you have 7 days to get the HBIG in. Gonorrhea. So the transmission is usually through way of vaginal secretions. The neonatal conjunctivitis actually happens on day of life 2 to 5. It results in profuse bilateral purulent discharge, resulting in corneal ulcerations eventually. Systemic complications could be pneumonia, sepsis, osteomyelitis, arthritis, meningitis, and scalp abscesses. Chlamydia is commonly concurrent. And this is the picture as was earlier in the PowerPoint of ophthalmia neonatorum as caused by gonorrhea. And it's purulent, very copious and purulent. Here's a picture of it crusted over. So the erythromycin eye ointment, or in some cases 1% tetracycline, this decreases the incidence of gonorrhea conjunctivitis from 10 to 0.5%, but it does not prevent chlamydia. If there is a case of conjunctivitis, emergent treatment with IV or IM ceftriaxone is required, and copious irrigation of the eyes. Baby would have to be admitted to the NICU and receive blood, eye, and a lumbar puncture for CSF cultures. Again, may need IV cephalosporin treatment for 7 days or as much as 14 days. Chlamydia. So if a mother is infected with chlamydia, 25 to 60% of infants will become infected. The transmission, again, is from vaginal secretions. The conjunctivitis presents usually a little bit later, from day of life 5 to 14, and possibly earlier if there was prolonged rupture of membranes. It's usually bilateral, initially very watery, that becomes purulent, becomes swollen, and with red eyelids, with thickened conjunctiva. The pneumonia, the chlamydia pneumonia, usually presents between 4 and 12 weeks. And here's a picture of chlamydia conjunctivitis, at least initially, with the watery discharge. So what do? We would culture conjunctival scrapings. Again, erythromycin eye ointment will not prevent. The conjunctivitis or pneumonia would be treated with erythromycin orally for 14 days. If mother's untreated, if there's an untreated mother, the infant is at high risk of infection, but treatment is not indicated until infant has clinical signs due to the unknown efficacy of prophylaxis. So, what is this picture? Can anyone tell me? Well, it's not something infectious actually. So this is the eventual appearance of these initial pustules here. This is what they turn into. So this is actually transient pustular melanosis. It is benign. It often presents in darker skinned infants. It's a rapid onset of diffuse vesiculopustular eruption, which rapidly evolves into small pigmented macula, like in this picture here. Okay. It regresses spontaneously in a few weeks, but obviously I wouldn't make this call yourself. If you're concerned, please contact the MD or provider. And transitioning to herpes, so herpes simplex virus, or HSV. It's in 1 to 30 to 20,000 live births. 60% of cases of neonatal HSV are actually where mom has a primary or first-time genital lesion. In less than 5% of cases, mom has a secondary lesion, meaning she's had a history of it, but had, say, a breakout during delivery. Why is it the case that less cases are where mom has a history and has a secondary lesion? It's because she's had the disease for so long, so antibodies have time to cross the placenta and protect the baby. So the learning lesson there is that most neonatal HSV cases are actually born to women who are asymptomatic and without a history of HSV. Okay, so this is the main reason why there's no routine screening during the pregnancy, testing-wise. 95% of the transmission occurs at the delivery. So the big question is always going to be, did mom have an outbreak in the third trimester or at delivery? That's what really matters, okay? Did mom have a recent outbreak, third trimester or at delivery, okay? What are the risks? Prematurity, fetal scalp monitoring, prolonged rupture of membranes. And there's a whole algorithm on how to proceed on each specific case. And recently I've been just contacting ID if there's any question. But generally, if you have a low suspicion, you still have to get surface cultures and or PCRs of the conjunctiva, nasopharynx, and rectum. The rectal sample is kept separate. If there's a really high suspicion, that baby has to be admitted to the NICU, has to get blood and lumbar puncture for CSF culture, surface cultures or PCRs, LFTs, and has to be under contact precautions and may need acyclovir for 14 to as much as 21 days. And these babies do go home with oral treatment for 6 months. And this is an example of what neonatal HSV looks like. It's angry appearing, really angry appearing, just very distinctive and striking. Another example there. Tuberculosis. So this transmission of tuberculosis is usually postnatal through respiratory droplets or secretions and through mucous membranes. Congenital TB does exist, though. There have been cases where it's been shown to be transmitted placentally or through amniotic fluid. Neonates are at higher risk of disseminated disease, obviously, and the way that would look would be with hepatosplenomegaly, respiratory distress, fever, lymphadenopathy, abdominal distension, lethargy, ear discharge, skin papules. So specific cases. What if there's an asymptomatic neonate and mom has a positive PPD or tuberculin skin test? If mom has a normal recent chest x-ray, no separation is needed and breastfeeding is okay. If mom had an abnormal chest x-ray, you got to separate mom and infant and confirm if this is active disease or not. If it is active disease, the infant may need a multi-drug regimen, or the mom may need a multi-drug regimen including isoniazid, rifampin, ethambutol, and vitamin B6 for 9 months. And the infant may need isoniazid for 3 to 4 months. If there's a case of congenital TB, I would definitely consult infectious disease in that point, and the baby again may need a multi-drug regimen, including isoniazid, rifampin, pyrazinamide, and aminoglycoside, and corticosteroids if there's meningitis. In terms of isoniazid, there are no adverse effects in breastfeeding. After infant receives isoniazid, there's no separation needed unless there's multi-drug resistant tuberculosis or poor compliance. Mom must still wear a mask, and express breast milk can be given unless there is tuberculosis mastitis. And a summary of breastfeeding contraindications in the United States. If there's maternal HIV, there are countries in which breastfeeding is still recommended despite HIV. Those are more lower resource settings. And there have been cases that actually I've seen here after training that where with the blessing of infectious disease, like mom has been followed by ID, they have okayed breastfeeding in that case if mom's maternal viral load has been controlled. if there are HSV lesions on the breast, breastfeeding is contraindicated. If there's presumed active tuberculosis, if there's tuberculosis mastitis, if there's a breast abscess, and there are certain situations that are not specifically contraindicated, but if there are maternal oral active HSV lesions, if mom is CMV positive, and the infant is at risk, like being a very low birth weight infant. So maternal history that is non-infectious related. Okay, some of these are very important. So maternal thyroid disease. The biggest thing, and really the only thing that affects the infant, is maternal Graves' disease, and it can affect 1 in 50,000 infants. So what happens here? In Graves' disease, it's an autoimmune disease where mom creates antibodies against her own thyroid, which usually stimulates her thyroid. Okay, these antibodies can cross the placenta and either stimulate or block the infant's thyroid. 90% of the time it is stimulating, though. Okay, so if mom is on thyroid medications, ask why. Okay, if mom had a thyroidectomy, ask why. Is it due to Graves'? It could be due to Graves'. In this case, mom still has these antibodies, even though her thyroid has been, part of her thyroid has been removed. She still has the antibodies, and these antibodies can still pass to the fetus. Okay, so really a lesson here is, if mom is on thyroid medications, ask why. Okay, Hashimoto's, thyroid malignancy, a thyroid nodule, these things don't affect the infant, but Graves' is the one that does. Okay, so effects of Graves' can present in utero and up to 4 to 6 weeks after the infant's born. So a couple of medications that are really important to ask why are PTU, or propylthiouracil, or methimazole. Okay, these are thyroid blocking medications, and if mom is taking these, they can actually hide the infant's symptoms. Okay, so if you see any of these things, ask why. What is your thyroid disease? Why did you have a thyroidectomy? Why are you on PTU or methimazole? And one thing that we don't practice here, but if we could, it would be great. If we could get cord blood for a TSH receptor or thyrotropin receptor antibody, okay, also called TRAB. If we could get this from the cord blood, we could 100% rule out Graves' disease in the infant. Okay, it has a 100% negative predictive value. So at some point, maybe we can talk about this more, but that's one thing we could do. Otherwise, what we do is we test the infant. We could test the infant for the same things and get TFTs in a few days. So, maternal lupus. If you see a case of maternal lupus or even maternal Sjogren's, the one question to ask is, does mom have anti-Rho or anti-La antibodies, also called SSA or SSB? These antibodies can cross the placenta and attack the cardiac conduction system with permanent effects, actually, namely congenital heart block. So if you see an infant with heart block, it may actually be the first presenting sign for the mom of lupus. What other things might you see? A rash, abnormal LFTs, cytopenias, cholestasis, encephalopathy, or even fetal hydrops in stillbirth before birth. And you can check out these references as well. And I hope this was productive and fruitful. And my goal is for this to not only help you now, but again, help you help your careers as you go forward in whatever you do, whether that be family practice or midwifery or other units, etc. So this was fun, and I hope to do more of these. And if there's any specific topics that you want to hear about, please let me know. All right, thanks. Bye.